Welcome to The Explainer. Today, we're tackling a massive, multi-billion-dollar question. Whether you're a healthcare professional, a policy student, or honestly, just a taxpayer wondering exactly where your money goes, we're going to break down a really complex topic into plain English. We're looking at a comprehensive policy report put together by a grassroots organization called Healthcare for Illinois, titled The Case for Medicaid Deprivatization in Illinois. We're going to impartially unpack the data and the arguments presented in this fascinating source document to really understand the nuts and bolts of public healthcare administration.
Okay, let's dive right into this. Here is our roadmap for unpacking this complex policy paper step by step. We're going to cover 1. The Illinois Medicaid dilemma, 2. How managed care works, 3. The Connecticut case study, 4. Comparing MCOs and ASOs, 5. Potential financial savings, and finally 6. A citizen-driven path forward.
Section 1. The Illinois Medicaid Dilemma, Evaluating Decades of Managed Care.
You know, for over a decade now, Illinois has relied pretty heavily on private insurance companies to manage Medicaid for millions of its residents. We are talking about a massive, absolutely critical infrastructure system that covers kids, seniors, people with disabilities, and working families all across the state, all funded by our tax dollars. But the driving question posed straight from the report is simply this: has the system actually delivered on its promises? The original goals of privatization made sense, right? Improve care coordination, control costs, and make state budgeting a lot more predictable. But the source material asks us to just hit pause for a second, step back, and evaluate if the current setup is actually achieving that in practice.
Well, when we look at the current landscape, the report highlights some pretty massive systemic challenges, mostly based on direct feedback from providers. We're talking about delayed patient care, ever-increasing administrative hurdles, incredibly fragmented billing rules across all these different plans, a drop in participating healthcare providers, and just overall high systemic expense and complexity. The authors make the case that these aren't just, minor paperwork annoyances. They're literally the difference between a doctor treating a patient and a doctor battling a web portal. And that is real-world human consequences, like severe provider burnout and unintended barriers for people just trying to get care.
Section 2. How managed care works. From fee-for-service to MCOs.
To truly evaluate the reforms proposed in this report, we first need to make sure we understand how the baseline system, known as Health Choice Illinois, actually functions today. So the crucial point here is understanding the mechanics. Think of an MCO, or managed care organization, kind of like a general contractor that you give a fixed budget to. That fixed budget is called capitation. Essentially, the state pays a set, predictable fee per enrolled Medicaid member, and then the private MCO manages the delivery of that care. Crucially, they're the ones who absorb the financial risk if the costs happen to run over that fixed amount.
Now, the state's intent in moving to this model was to shift away from that old, unpredictable pay-per-procedure fee-for-service billing. The theory was that a single private organization could do a much better job tracking a patient's overall health, prioritize preventative treatments, and ultimately prevent those super expensive emergency room visits down the line. And of course, bring some much-needed predictability to state budgets.
Section 3. The Connecticut case study, a different administrative path.
This brings us to Connecticut, which the paper uses as its central real-world case study. They do this to demonstrate that an alternative approach isn't just some pie-in-the-sky theory. It's already been done successfully. After years of using a traditional managed care model, which was very similar to what Illinois uses today, policymakers in Connecticut stepped back and realized the structure itself needed a serious overhaul to improve both efficiency and data transparency.
So, in 2012, Connecticut made a massive pivot. They completely replaced private managed care organizations with a system supported by administrative services organizations, or ASOs. The key difference here? They basically carved out the administrative tasks, treating it like a flat fee processing service, but without handing over the actual insurance risk.
Section 4. Comparing MCOs and ASOs. Where does the financial risk lie?
All right, we're transitioning to the core comparison of this explainer. If you really want to understand the difference between these two models, you've got to follow the money. In the Illinois MCO model, private insurance companies assume the financial risk. They receive those fixed payments and have to balance all healthcare spending against that set amount. In stark contrast, the Connecticut ASO model means the state itself retains the financial risk. The private contractors are paid purely for administrative services, not for managing healthcare costs. The report impartially points out this inherent tension. MCOs face a constant push and pull between paying for care and controlling costs so they can stay within their capitation limit, while ASOs simply process the paperwork for a flat fee.
Breaking this down just a bit further, to really understand duplication and standardization, take utilization management.
In Illinois, that varies wildly across multiple private MCOs, but in Connecticut, it's completely standardized under unified state Medicaid rules. Structurally, Illinois is operating multiple, parallel, somewhat fragmented systems, whereas Connecticut uses a single, centralized administrative structure. And regarding those financial incentives, Illinois MCOs are incentivized to lower healthcare costs to maintain their margins, but Connecticut ASOs are paid only for the administrative tasks they actually perform. It's a complete shift in where the incentives lie, and the authors argue this dramatically cuts down on confusion for doctors and hospitals.
Section 5. Potential financial savings. Efficiency over administrative layers.
So what does this all mean for the bottom line? This brings us to the financial projections the paper proposes if Illinois were to actually deprivatize its Medicaid administration using these lessons. 5 to 10%. That's the number to remember here. The report identifies this as an aggressive, sure, but highly achievable target for reducing Medicaid administrative costs over time. Now, in a state Medicaid budget this large, that is a staggering amount of money. We're talking potentially hundreds of millions of taxpayer dollars. By stripping away all those overlapping private insurance infrastructures, separate claims platforms, different authorization portals, multiple corporate profit margins, the state could theoretically reclaim all those funds.
But look, this isn't just some dry accounting exercise. Redirecting that 5 to 10% translates to massive human outcomes. The source paper strongly advocates for reinvesting those hundreds of millions of dollars directly back into patient care. We're talking about tangible things, like improving provider reimbursement rates, stabilizing at-risk rural hospitals in your community, expanding access to behavioral health care, increasing preventative care services, and just generally reducing overall barriers to treatment. The goal they are arguing for isn't just a cheaper program, it's a substantially better, much more humane one.
Section 6. A citizen-driven path forward. The Illinois Care Initiative.
So how do we actually get there? The report proposes a very grassroots methodology for evaluating and implementing these potential state-level reforms. Organizations like Healthcare for Illinois are pushing hard for a transparent, statewide process. They want to create a proposed Illinois Healthcare Reform Commission to hold community forums across all 102 counties in the state. The whole idea is to design a system based on ground-level community input from the people actually using it, patients, doctors, taxpayers, rather than just waiting around for top-down political mandates.
Which brings up a really great question straight from the paper. What can Illinois do now? The authors make the case that states really shouldn't just sit on their hands waiting for massive national consensus, like Medicare for All, to come along and fix this administrative bloat. Because, let's be real, a national consensus could take decades. They argue that Illinois has the ability, and honestly the responsibility, to act right now to simplify its own systems.
So what should the next generation of Illinois Medicaid look like? We're going to leave you with this provocative question from the source material to ponder. It challenges all of us to consider the future of healthcare administration, that super delicate balance between private expertise and public oversight, and deciding the absolute best path forward for a system built around people rather than administrative complexity. Thanks so much for joining this explainer, and keep exploring.